control. That's
There
how
should
I
be
do
a button too.
it.
Yeah.
Okay, cool. So this is Abdo X-rays. It was meant to be at the end, but I've just been really disorganized with my timings today, so I'm going to go first. Okay, so it's very specific to Mod B people, but like if you're doing acute, it could come up as well. And generally, it's just something nice to have an awareness of because you never really get taught it. So just start typing things into the chat. When would someone order an Abdo X-ray? What could be wrong with the patient? Yep. Anything else? I'm gonna, yeah. So exactly, yep. So the like phrase that I find useful is gases, masses, stones, and groans. And if you break that down, this is what each of them sort of like roughly kind of indicate. So the gases are like if they've perforated any sort of process that generates loads of gas, so like IBD. Any masses, so like palpable ones, obstructing ones, any foreign bodies. Stones are just stones, and groans is like anything that causes the person to like feel constipated, feel obstructed. Don't worry if you don't recognize all of these now. I didn't at this time, but this is sort of the main reason why someone would order an Abdo X-ray. Okay, so this is what it looks like, and the process with any X-ray, Abdo X-ray, chest X-ray, limb, whatever, is the same every time. So you just check the details, assess like the actual image itself. Can you interpret this? Is it good quality? Is it good view? And then you like actually see what it's showing you. Look at the organs, the important stuff. And then you do your review areas. And I never really understood what, like, you can't see me, but I'm doing like quotation marks with my fingers. But I never really understood when people used to say to me quotation areas, review areas, what that means. And basically, you work it out after doing loads of them yourself, but it's basically stuff you really forget. So if you always forget to look at the spine, or like if you practice loads and you're like, oh, I always forget to check above the liver, that's your review area and that's personal to you. So similarly, like with a chest X-ray, if you always forget to check the ribs, that's your review area. And then the last thing is, after you've done all of that, go back and see why they actually had the X-ray in the first place, see if what you're finding matches up with their symptoms. And this is especially important for Abdo X-rays because half the time you can kind of guess from the indication, like you can kind of guess from their symptoms what's wrong with them. So does anyone have any questions before I carry on? Okay, no, cool. Okay, so we'll start with quality and view. So there's two ways you can assess the quality and view. The view, you basically check that you can see everything from left to right and from like their diaphragm down to sort of their pelvic outlet. Can you see where I'm pointing? Can they see where I'm pointing?
They cannot.
Would I do right before this? You could do right before this, but it is, as in like some of it is just a bit not applicable to an Abdo X-ray. Like penetration, I don't really like, no one really cares how penetrated it is. It doesn't really make a difference. So it's only really for a chest X-ray, right? But for you, quality and view, I would recommend doing. So if you can remember right, then you'll like just remember to do this before you start interpreting. So what was the deal with the pointer? They can see it or not?
No, they can't.
They can't.
It isn't
okay.
a thing. Yeah.
Oh, okay. So the view is that all Abdo X-rays, it's not like chest where it could be AP or PA. All of them are AP. And most of them are supine, but you can, for certain reasons, I'll come back to it, you can order an erect one. And if you really want to just look at the very top, like just the diaphragms and the bit below it, you can also do an erect chest X-ray. And the quality, you basically determine it by going left to right. And what you're really looking for is that you see the air outside the person on the left, the like real black bit, and the air on the outside of the person on the right hand side as well. So you just follow it across and it goes from black to black. With the diaphragm to hernia, hernial orifices, it's just sort of from like can you see the bottom two ribs, to like, can you see their hips, basically. Okay. And yeah, if you're presenting, like, just don't get bogged down in this bit, just to be like, it's supine AP and I can see it clearly in both directions. Okay, so the next thing is that you check your organs. Obviously, these are a lot of things, and I'm not going to go over all of them today. But what I will say is just have a system so you don't forget it. So my system is I go from top to bottom twice. The first time around, I do top to bottom of the GI tract. So I go stomach, small bowel, large bowel, rectum. And then I go top to bottom again with non-bowel. So I go kidneys, liver, spleen, pancreas, and gallbladder. Sometimes you can see them. And then the spine and pelvic area. So it doesn't really matter how you do it, just have a system so you don't ever forget anything. When I looked at this, I was like, what's the big stuff that I want you guys to like be able to spot? And there's 2 or 3 big pathologies that we're going to just discuss today. The bowel is kind of the main thing that a lot of people look at when they order an Abdo X-ray. So I've just given that away. Can you guys put in the chat how to tell the difference between small and large bowel? Anything that you think might be helpful? Sometimes, yeah, yes, okay. On the right lines. Location, yes. Anyone else want to add anything? How? Yeah, exactly. Okay, so your small bowel, like Chris said very rightly, is located more in your center, and your large bowel is located more peripherally. And like Alex said, your small bowel tends to be smaller, your large bowel tends to be bigger. I wouldn't say it's filled with more air just because, like, I don't know the volume of it, but like physically it does tend to be bigger, the large bowel. And then the biggest difference, or like the most reliable difference between the small and large bowel, is its like valvulae or haustra. So if you're ever looking at some piece of bowel and you're like, got no idea what this is, so the top 2, like its size and location, are helpful, but like the most sensitive, I would say, is looking for like haustra or valvulae. And what I mean is, this is your small bowel and these are its valvulae. They go all the way across. You can't see my pointer, so I'm just going to hope that you can see. And with the large bowel, the haustra don't go all the way across. And when you look for those, look like across like 5 or 6 different ones, because sometimes you can convince yourself that it does go all the way across when it doesn't, and then the one next to it doesn't. So you're like, right, which one is it? So like just do an average of like all of the ones you can see, basically. Okay, so the common thing that people order Abdo X-ray for is to work out if someone has bowel obstruction. And do you guys know what the rule is to spot whether someone's bowel, once it's obstructed, it dilates? So everything like leading up to that obstruction is just like getting plugged up and filled up, so it dilates. And that's what you look for in the X-rays. Does anyone know what the rule is called to check if something's dilated? Okay, I'm just going to tell you. It's called the 369 rule, and that basically is how many centimeters each section has to be like bigger than before it's classed as dilated. So like if it's more than 3 centimeters and you're looking at the small bowel and it's bigger than that, it's dilated. Similarly, 6 for the colon, 9 for the cecum. Okay. And if you get obstruction that goes like so far that like everything dilates, eventually the whole thing just like pops, basically. That's what I'm picturing, and that's what like medically they call perforation. So when that happens, all the air inside the bowel just like seeps out. It's really painful, but the way you tell if someone has perforated on a bowel X-ray is by looking for air free in the abdominal cavity. So there's a very pathognomic sign for this. Does anyone know what it's called? Okay, no. So it's called Wriggler's sign. And And I'm going to try and I really wish I had a pointer for this now. But basically, if you look at the left-hand image here, when you look at the edges of the bowel, you can see the edge that's on the inside, but you can't really see the edge on the outside. It's just merges with the rest of the white area. Whereas in Wriggler's sign, because there's air literally on the inside and the outside of the bowel, you can see both edges really clearly. Tell me if you understand. Otherwise, I'll just get a pointer or start drawing on this thing. Can you actually see the difference? Yeah, not really. Okay, that's fine. Guys, how do I draw on this thing?
You can't, but I will try and get a good image of it.
Okay. So it kind of makes sense. Okay, so if you guys look at the left-hand image has 4 vertebrae, right? So if you look at the second vertebra and look at the bowel on the right-hand side of it, right, you can spot its haustra. And if you follow the haustra and you get to the right-hand border of the bowel, right, you can see where it swaps from being air to some kind of tissue. And then just follow that whiteness, and you don't really know where it ends, right, until you get to the next part of the bowel. Yes? Or no? Yeah. Okay, now do the same thing with the right-hand picture. So start with one of the arrows, look at the inside of the bowel, and then oh, did I do that? Okay, yeah, you might have to rejoin. Is it bad for anybody else?
I can't see it either.
Why is this happening? I'm now changing between the slides. Can you guys see that?
Yeah.
Okay. What about this?
Yeah, I can see it.
Yeah.
Okay, so yeah, so we're on the right-hand picture now. So start with one of the arrows, start with the inside of the bowel, look at the edge where you see it go from black to white, and then keep following the white. You won't have to follow it for very long before you see it go black again. Does that make sense? Or more sense, I guess. Yeah. Exactly. And Anusha's just put another photo in the chat. The other way you can tell, which I think is much easier actually, whether someone's perforated and there's free air is, well, air will rise. So just look for it above the liver and just look for it under the diaphragm. But remember, it's only pathological if it's on the right-hand side. On the left-hand side, that's just air in the stomach. That's perfectly normal. But on the right, it's not. The only caveat to that is, say you're on a ward and you go and clerk a patient and you kind of figure out what's wrong with them. You know they've had some surgery, don't really know what, didn't really palpate them, kind of have no idea what's going on. True story, just saying. And then you go back and you look at their abdo x-ray and you're oh my God, they've got air under their diaphragm and they're not in pain. Don't panic. That's not them perforating. That's just because they've had laparoscopic surgery. And when they have laparoscopic surgery, they pump air into your abdomen to get a better view. So it takes a few days before all of that air gets reabsorbed. And I'm calling it air, but actually it's CO2. And it's specifically CO2 because oxygen's flammable, so you can't use that. But yeah, if you want to sound clever, someone find out for me whether reabsorbing all of that CO2 has the potential to make them acidotic, because that'd be very interesting to know. Okay, moving on. That was my small tangent. We're going to play a game of obstructed or not. So I want you to tell me if these are obstructed, and if they are, if they're small or large bowel. Okay, so obstructed or not, small or large bowel. Just guess if you don't know. So it's yes, but it's large bowel. Exactly. So if you, glad you spotted that it's dilated, but if you look across, there's enough valvulae for you to convince yourself this is small bowel. I know there are some that don't go fully across, so you're like, is this large bowel? But this is definitely small bowel. And the loop of bowel towards the like middle near the vertebra kind of solidifies that answer. Okay, next one. I've just given the answer away. What's wrong with me today? This is large bowel obstruction. And yeah, you can see valvulae and it's dilated. That's all you need to be able to do to work out whether it's large bowel obstruction. Okay, so the next one. Oh, what else could this be? I don't know what I was thinking when I wrote this, so who knows? We're just going to skip this answer because I don't even remember what I meant there. Oh, I do actually.
Toxic megacolon.
No, I was thinking something else. Okay, what else could this be? It's not toxic mega. Any ideas? No. Okay, this is tangent 2.0. So this could also very easily be pseudo obstruction. And I'm not going to go into like too much about pseudo obstruction. If you're really interested, when you get the slides, have a look in the comments. But basically, in like when you have true obstruction, there's like a solid lesion or like there's something that's physically obstructing it. In pseudo obstruction, everything that happens in obstruction happens, but like anatomically there's nothing there, and it's not a functional problem. It's not like this person's, and it's not like a psychogenic thing. Someone's not making up that they're like bowels dilating. It's physically happening, but there's no like anatomical like stump or anything inside them that's like causing the blockage. And often this is what people worry about. Like they look at, and the management for the two are very different as well. So like I've seen a lot of doctors on the ward be like, is this obstruction? Is this pseudo obstruction? Who knows? And the only way you can really tell is with a CT. Like you physically just get a CT and look through for a physical obstruction. And in the context of like an old person who's had a stroke, people start considering a bit more. So just remember that basically. It's also why if you refer to a surgeon and be like, can you fix this person's obstruction? They'll be like, get me a CT. It's not just because we think every surgeon wants a CT to like see everything before they have their surgeries, because they just want to rule out a lot of things. Okay, so getting harder, next one. Obstructed, not obstructed, small or large? Someone guess. Not obstructed, okay. Anyone else? Okay, well, it's actually obstructed. And the reason why I said it's getting harder is because this is small and large bowel obstruction. So what's happened is they've got an obstruction really far down their GI tract, but they've also got an incompetent ileocecal valve. So the valve between your small and large bowel doesn't work, which means like it's not just the large bowel that gets blocked up, it's both the large and the small bowel. So this is quite bad, it's quite severe. Okay, next one. What's happened to this patient? Yeah, they perforated, well done. So you can see free air under their diaphragm if you can't work out what the hell's going on in their stomach, which I can't either, but they perforated. So this is large bowel obstruction and they've popped, basically. Okay, so the next thing that is like quite common that I want you guys to take home from today is volvulus. If you don't know what volvulus is, don't worry, I didn't. But there's two main types, and basically all it means is that the like bowel twists on itself and then you get obstructed. But there's two very common ones, and it happens either in the sigmoid or in the cecum. Now, going back to like first year anatomy, if you twist around your cecum and that gets blocked, you get small bowel obstruction. If you twist around your sigmoid and that gets blocked, you get large bowel obstruction. Is that clear, firstly? I'm going to assume that is. So there's a few differences between a cecal and a sigmoid volvulus. The sigmoid one happens because as you age, your mesentery just gets a bit longer, it's less fixated, and it happens in older people. Whereas the cecal one, it happens because, again, flashback to first year anatomy, when like you're embryologically being like made, your bowel has to like come out and then it twists and it goes back in. So if like something goes wrong in the twisting, or it's like ever so slightly misplaced, you might be more prone to twisting. So it happens in younger people. And a lot of people say that the like classic sign for sigmoid is, does it look like a coffee bean? And if it does, then it's sigmoid. If it doesn't, it's cecal. But both of these pictures to me look like coffee beans. And the way you can kind of tell is you follow the center of the dilation. So on the left-hand picture, you can see that there's an arrow pointing to the center of it, and you can see that it goes from like right lower quadrant to left upper quadrant. And that means that it's started in the right lower where your cecum is and moved up. Whereas the opposite happens on the right hand picture. So like if you follow the center, it kind of points to the left lower quadrant where your sigmoid is. It starts there and then pulls up. Is that clear? Okay, I'm just gonna assume it is. So we're gonna play another game. That slide should have been deleted, silly me. Sigmoid or cecal. So is this a sigmoid or cecal volvulus? So this is cecal. So again, Nicole, if you, yeah, exactly. So if you follow the like white line in the middle of this like big round black thing, it starts in the right lower quadrant and then it goes like diagonally up. So right lower quadrant, that's cecal. Okay, cecal or sigmoid? Oh, don't worry, I'm just glad you tried. Being shy gets you nowhere. Just saying. Okay, this one is cecal as well. So it starts kind of on the right hand side. It is a bit hard, but this one starts on the right hand side again, and it's kind of got two stems, but both of them go sort of from the right to the left, so it's more cecal. This next one. Yeah, this is sigmoid, exactly. This is very, very classically a coffee bean, exactly, good. This one? This one's a bit harder. This one's also sigmoid, good, well done, yeah. Okay, so this is my last slide. I didn't want to overwhelm you guys, but the only other sort of big thing that I could remember you might want to know about abdo x-rays is that in ulcerative colitis, if someone has an acute flare, and for some reason they get an abdo x-ray, what you can see is this really pathognomic sign of thumb printing. I really wish you could see my pointer. So if you look at this picture, on the left hand loop of bowel, you've got like the loop that kind of cuts off in the picture, but the one that's like fully in the picture, if you look at its edges, it kind of looks like someone's just like shoved their thumb onto it. Can you guys see that? It's really clear on its left hand edge. Yeah, so that's thumb printing, and it happens when the bowel thickens, and you see it in UC. So if someone ever asks you, oh, like, what's thumb printing classical of? It's ulcerative colitis. And yeah. Oh, this is now my last slide. In ulcerative colitis, if this gets really extreme and they get loads of colitis, no one really helps them, they can get like toxic megacolon. This is I'd say a surgical emergency. Anyone else back me on that?
Yeah.
Yeah,
it is.
thanks.
But you can also medically manage it, but we'll go over it another time.
So this is when someone has like UC, they've got it and they've got their flare, and it just like their transverse colon is huge. So if you ever see this, this is toxic megacolon. It looks very much like bowel obstruction, but like there's not a lot of other bowel around that's obstructed. So and this is what I mean by like at the end when you've seen all this, your differentials will be like toxic megacolon, bowel obstruction, and then you like go back and read the stem and you're like, oh, they've got a history of UC, okay, they've got toxic megacolon. So like always go back and look at indication. Okay, I think that's my last slide. Thank you for listening. I meant to be in South London in 45 minutes. It's not going to happen. But if you have any questions or any feedback, or want any more, just like put it in the form, message me, email me. Hopefully this was helpful. And if you are at the free or at the WIT, this is how you go and look at someone's abdo x-ray. Don't go, there's still more to come. This is someone else, like James and Izzy still need to do their thing. But this is how you could bring up someone's abdo x-ray if you needed to on the PAC system. Cool. Any burning questions before I go and run to the tube?
Okay, cool. So I'm going to talk to you a bit about the most kind of common blood test that you'll probably get asked to do now that you're kind of doing the internship model. This is the lavender bottle, which does full blood count, blood film, just like your true bread and butter medicine, basically. When you're asked to do this, it will give you your sort of hemoglobin values, some of your inflammatory cells, so your neutrophils, your eosinophils. It'll also give you your ESR, which is your erythrocyte sedimentation rate, which is one of the inflammatory markers alongside the CRP. They're essentially very unspecific and will be raised in infection, inflammation. But if you see it popping around, that's why, like, what it's for. It'll also do a blood film. So I'm sort of going through this topic and I understand it's like, it was FHMP first year, cows of us like looking at blood films on computers and didn't really know what's going on. So don't be like too hard on yourselves. Like hematology is difficult and we did it so long ago. So it'll take a while, but this should be some basics for you guys. So there's a few other random things on in the lavender bottles. There's the Epstein-Barr virus monospot. There's HbA1c, which is your glycated hemoglobin, which is your classic one for testing for diabetes, and parathyroid hormone, but I'm not really going to talk about those. The main thing for when you're on the ward and you're taking blood is that quite often, especially when you're starting, you don't fill up the whole blood bottle. And just to make the point that even if it's half filled, you can send this off and they can get most of the info for you. It's only really like the ESR that needs a full bottle. So if someone asks you and you think that you need to keep redoing them, you don't, just send it. So these are the values, and often everything's abbreviated. And for some strange reason, I decided not to put the hemoglobin values, which was a mistake. So normally for men, over 90 is kind of the common is normal, and over 80 for women. And yes, as Anu said, you'll be given everything for the exam, but like it's good to know some of the common ones just so that you're like fluent in it for just being on the wards. But the common ones to look for anemia would be your hemoglobin level. So if it's low, they've got an anemia. And then look at the mean cell volume, which is the size of the cells. And you categorize your anemia based on the size, which we'll do shortly. You've also got your mean cell height and your ferritin, which is your measure of iron stores. And then it also gives you your white cell count and your neutrophils and all those other ones. And probably from IDs, some of you'll remember like neutrophils are usually raised in bacterial infections, lymphocytes raised in viruses. But just to bear this in mind that often with some patients, especially cancer patients, if they've got an infection, sometimes these counts are low. And we know from coronavirus as well that these patients often present with a lymphopenia as well. So just being able to comment on what's high, what's low, and just keeping a broad mind about things is really helpful. And one thing to bear in mind is, like, throughout this whole year, you're going to get all these nuggets of info that, you know, some of these will be raised in autoimmune diseases, some will be raised in cancers. Like, there's plenty of other things other than infection that you should bear in mind. And it's fine to get things wrong, like on your first few weeks, so don't worry. So this is just like a general question. Does anyone a percentage is fine, or a number? Does anyone know how many of the world's population are anemic? Like, just throw it out there. Anoush can guess. Someone can guess. Okay, 15%, not bad, not bad. Okay, yeah. So it's actually pretty, I mean, I think, yeah, Nicole's probably like the closest, and Anoush, but basically 1.6 billion are, and it's almost 25% of the population. And what's interesting is that this can even be young children. So it spans all age groups. So you're going to see this a lot in hospital patients as well, especially. This is, a big problem worldwide, essentially. So you're going to see this all the time. So what is your patient going to present with? So anemia is either a reduction in red blood cells, or it's a reduction in the oxygen capacity of those cells. So if you're not getting enough oxygen to tissues, you're going to feel weak, you're going to feel tired, you're going to have dizziness because your brain's not getting enough oxygen. I've even seen someone who had blood loss that caused, cardiac chest pain because they weren't getting enough oxygen to their heart. So overall, there's like quite a lot of symptoms that the patient can present with, but most commonly they'll be tired, they'll be pale, and they won't be able to exercise. Okay, sorry. So we're all learning, and I am learning how to do animations. But so when we classify anemias, we classify them based on size. And I think that hematology is a lot of doing these diagrams. So we start off with our cells that are small, so microcytic, and then we do our normocytic anemias, and then we do our macrocytic anemias. I don't know if someone keeps grabbing control of my slides. They keep kind of jittering, but yeah. So if you look at the blood film in the middle, you can see that the cells are pale and that they're small. Like, I think maybe I could convince you that they're small. So this is kind of what you'll classically get with these patients. So if it's a microcytic anemia, what we want to know is it low iron or is it normal iron? Because one of the big causes of a microcytic anemia is that they have iron deficiency. And if we talk about iron deficiency anemia first, your patient will present with kind of, there's a few constellations of signs, and you might have learned these, I think, already, a couple of them. So does anyone know what any of these signs are called? So like there's the person pulling down their eyelid, and you don't have to use the correct terms, you can sort of describe. Yeah, so conjunctival pallor is how they'll describe it. Does anyone can anyone describe sort of what that nail looks like? Yeah, so it's the koilonychia. To be honest, I don't really know how you remember easily that leukonychia is like the white patches. But yeah, that's koilonychia. And then this is angular cheilitis, which is around the lips, which is what they can also present with as well. Oh yeah, leuco white, yeah. Okay, so if we move on to the normal ferritin, so the problem with heme is there's so many different things, and we'll go over this, throughout the year, different things. But the big one, if you've got someone who comes in who's got microcytic anemia, normal iron is like thalassemia, which is one of the genetic conditions that affects the structure of hemoglobin. I think we won't go over this in great detail today. We'll go over it separately. But I just threw this in for interest. They basically get red blood cell production in places that aren't just the long bones, and they get this hair on end appearance of their skull. So they get this enlarged, they'll get an enlarged forehead, and you'll be able to see this hair on end appearance, but we'll go over that another time. Maybe it can just be floating in your mind. Okay, so what are the causes of iron deficiency anemia? So I like to present this in 3 different categories. So either your intake is rubbish, so you're just not getting enough, through your diet. Your absorption is rubbish, like my handwriting. And there's too much like consumption of the iron, or like you're losing too much iron throughout whatever way. So reasons for poor intake. Does anyone have any suggestions? Yeah, so it'll come on a bit later, alcoholism. But yeah, one of the things is like they're just going to have they're probably not going to be eating normally. They might be vomiting up some of their food. Yeah, vegans. So I'll bring it up. So vegans, the common foods for iron predominantly is red meat. You get it from spinach as well, but it's not your body can't absorb it that well. So vegans are highly recommended to supplement. And yeah, anyone that's on a really restricted diet, or just anyone who's, you could even get someone who's overweight who just isn't eating the fresh vegetables and the meats as well. So it's something to bear in mind. So absorption issues wise is a bit mod B in general. So anyone who's got a problem with their GI tract, that could be a chronic inflammation. Yep, so Crohn's, big one. Anyone it might sound really silly that you've got to suggest it to a consultant, but it's totally true. If they've had any bit of their gut removed, just like throat, it is an answer. It's better than idiopathic. And then one big one for the developing world, or any person that's come back traveling, is tapeworms and other parasites. They literally like leech off the blood. And then anyone got any ideas for consumption or loss? There's 2 big ones. These are probably the commonest reasons that you'll get someone with iron deficiency anemia come in to your GP practice or to A&E. Yep, so heavy periods. So menorrhagia is biggest, probably the biggest. And then what's another sort of source of, so chronic kidney disease, like you're on it. Why does chronic kidney disease cause low iron, iron deficiency anemia? Why does it cause it? In general, it's like, it's they get like rubbish absorption, and then also they get low levels of erythropoietin, which is the hormone that stimulates all of the red cell production. So they kind of have a bit of a combo going on. I think we can do a bit more nephrology another time, because I'm a bit rusty on it. Okay, so the other big one that we were going to mention, which I'm sure like everyone was thinking somewhere, is GI bleeding. So if they've got ulcer disease, like if they've been drinking lots of alcohol, and also a big one, the drug history is quite important in these patients, because we see it quite a lot where people take ibuprofen and they take way too much of it because they kind of just think it's this minor drug, but they've given themselves an ulcer and they've bled from it. So it's a good one to think about. And malignancy is in all of these, because if someone's on chemo and they're vomiting, they're not going to get it in. If they've got, it can affect their digestion, having the chemotherapy or the cancer itself. And also they can get GI bleeding from cancer. So it's always something to think about when you've got someone with iron deficiency, is do they have an underlying malignancy? Okay, and then that is a gross, don't look up tapeworms online, it's the stuff of nightmares. Okay, so normocytic anemia. So the cells are normal size, and the way to split these up, which I find helpful, is talking about these cells here, which have DNA remnants in them. So these are the reticulocytes. So it's whether you're finding high levels of reticulocytes on your blood films. And reticulocytes, the precursors to erythrocytes, and probably you'll remember vaguely from first year, is that they're pretty rubbish at carrying oxygen. So your body pumps them out to try and compensate for blood loss, and it just doesn't do a very good job. But if these cells are normal, it kind of suggests either that your body hasn't had time to compensate, your kidney function is bad and you're not producing enough of your erythrocytes, or a bunch of all other different kind of causes that we'll go over another time, because it's endocrine, it's very multifactorial, but it's just something to be aware of. Yeah. And also another thing is that often people who are iron deficient will also have B12 and folate deficiency because their diet is poor or their absorption of all of them is rubbish. So what's important to look at on the blood film is the distribution of the cells. So you can have some that are tiny because of iron deficiency, and you can have some that are really big because of folate and B12 deficiency, and averaging to quite a normal value. So that's probably more common than a lot of these options, but just something to bear in mind. But again, please don't feel overwhelmed, because hematology is very big and it does take time. And even if you remember a handful of things, it'll help you a lot. So the final group of anemias is probably the simplest, and that's the macrocytic anemias. So basically, the cells are too large, and you want to divide these into, are they megaloblasts, which are enlarged cells, but they're enlarged because of rubbish DNA synthesis, or are they just they're just big because they've got big, it's the cell membrane that's enlarged. So probably we were taught this, but I didn't remember it until I learned it in 4th year. But basically, folate is one of the precursor substrates for making the DNA in erythrocyte development, and B12 helps that as like a cofactor. So if you've got that deficiency, you get these abnormal nuclei in the cells, in the precursors, whereas for some reason, and I don't know why, the macrocytosis you can get if you if you consume lots of alcohol, that can just enlarge the cells. So to be honest, the only ones that you probably need to remember at this point in the year would be that you're thinking about B12 and folate deficiency, because that's a very reversible cause, and you're just thinking about supplementing it, or working your way around the absorption, or you're thinking about alcohol intake and liver disease. But yeah, as Anu said, renal is super complicated. So yeah, I think just having even being able to have just a systematic approach of what you're comfortable knowing at this point is really helpful. And also reticulocytes are bigger than erythrocytes as well, to just make your life even harder. So the other element of the lavender getting your blood samples is the blood films. So all I have to really say about this is that red blood cells come in lots of different shapes and sizes. And what I found useful to understand throughout the year was to make slideshows of example blood films. So for example, this one's normal. So the cells are all quite uniform. There are the neutrophils, which are the hypersegmented purple guys. And then, I had one that was like, this one's iron deficiency, so it's pale. They're smaller cells, they're all different shapes. And then these are like the large cells, which I can probably convince you of, compared to the neutrophil, they're a bit big. But I think that the Oxford Handbook has these tiny minuscule pictures of you can barely see what's going on. And I think just having that visual cue really helps, because you see something written down in a book and you just don't put 2 and 2 together, and it really just changes up how you think about it. And we'll go through this, we'll do we'll do a blood film a week or something, or we'll do something nice to make it a bit more digestible, because it often isn't. If you try and look at all of these at once, you just get overwhelmed. Okay, so back to asking you a question. I'm sorry, I've just been talking. So I'll give you a case. So this is Mrs. Betty Jones, and she's a delightful 75-year-old lady who presents to your general practice with chemotherapy-induced nausea and vomiting for gastric cancer diagnosed 1 year ago. You prescribe an antiemetic, so you make her nausea better, and this improves her symptoms. But a few weeks later, she comes back and she's complaining of feeling short of breath, fatigue, and having some dizzy spells. And we have just been talking about anemia, so don't worry, it's not going to be anything other than anemia that's the cause in this scenario. But what I just wanted to ask of you was what questions you think are important to ask this lady to work out what the causes of her anemia could be, and also which types of anemia you might expect and why in this lady. So if, yeah, any suggestions, there's lots of options, and no question is like, yeah, no question is like not important. Yeah, so normal diet, like what she's able to get in, you know, if she's been nauseous, is she eating her usual stuff? Yeah, drugs. So, you know, is she on painkillers that have given her an ulcer? If they're making her constipated, so she's not eating. Like all of this is like really good. And yeah, just the past medical history. Because you could realistically, you could expect any type of anemia for this lady. So she could have. I've got some example questions, and I'd say follow your structure so you don't miss stuff. But you know, just generally, you're asking how long this has been going on for, like the frequency of the vomiting, the frequency of the symptoms. Diet, 'cause you're wanting to check intake. You're wanting to ask her about a gastrointestinal bleed in case she's had that, 'cause she's got that gastric cancer. Drug history is really good. And I think what's also something to bear in mind is that just because someone comes in and has a long-standing condition does not mean that their symptoms are always the product of that long-standing condition. That is the case a lot of the time, but you know, she could have gone on holiday and got malaria. You know, she might have thought, well, I've not got long left, I'll go to, you know, I've always wanted to go on safari, and then she comes back with malaria. So just something to bear in mind about. But you'll do that as you get more experience, I think, and like further on in the year. And I definitely say for SBAs, very often the thing is the product of their long-term condition. So if they tell you something in the SBA, take it like on board, because it's usually them trying to give you a clue. But yeah, other than that, that's everything I had to say. I hope that it's been useful and you're not feeling too overwhelmed. We'll go much more into detail about specific areas of hematology throughout the year, so don't feel too worried. If there's any areas that you want to in particular, let us know, and we'll be happy to oblige. And don't worry if you hate blood films, because like it's totally fair enough, really. Oh, James, I can't hear you, but I don't know if it's you.
Yeah. We can't hear you, James.
My microphone should be on now. Can you hear me now?
Yeah.
Sweet. Okay, sorry about that. So yeah, we've got about 20-30 minutes left to go. Do you guys feel like you want a quick break to jump up and stretch your legs, or should we just power on through? Maybe raise your hand if you want like 2 minutes to stretch your legs. Okay, and now raise your hands if you'd rather power on through. Power it up. Okay, fantastic. Okay, so we'll try and keep it high energy, power on through to the end. Now that we've covered full blood count, we're going to cover some other really common blood tests. So I've put some examples there, using these, LFTs, clotting, TFTs, and a few other specialist tests. And by the end of this, we're hoping for you to understand what they are, what to look out for within the tests, and also importantly, when you're a doctor on the ward, why you're ordering them, and how to justify them on to the consultant on a ward round, so you look nice and slick. Okay, so we'll start with this one. Can anyone tell me, very basic question, what does UNE, what does a UNE stand for? Urine electrolytes, fantastic. And largely that's just about the kidney, really. Fantastic, great. Yeah, all of you are correct. And what a UNE will tell you is urea, creatinine, and it uses that to calculate this EGFR thing. And the only electrolytes it tells you is sodium and potassium. So don't get caught out if a consultant asks you what you get. Calcium or whatever, things like that, they're not included. It's only sodium and potassium. For today's talk, because I want it to be relevant to all of you, no matter what module you're on, we're going to focus on this EGFR, which is stands for estimated glomerular filtration rate, and effectively it's a measure of kidney function. More specifically, it's the amount of blood, the volume of blood, which is filtered by your kidneys per minute. So it's milliliters per minute, and the 1.73 meters per squared is just a correction for your body surface area. And in terms of normal values, the two numbers you should remember, which will be useful, is the number 90. So if it's above 90, it's absolutely normal. Kidneys are in tip-top form. It's only when the eGFR falls below 15 where you start to worry about replacing the kidney function, either with dialysis or transplants. There are grades in between which you use for chronic kidney disease scoring, but I'll save that for a renal talk. These are the useful ones for all of you to know. It's also worth saying that your kidneys are pretty good, and they still kind of work until they get lower than 15, so they compensate pretty well, even if it's say something like 50. And your eGFR, like I said, is calculated from your creatinine levels, but the formula to calculate it also uses your age, your gender, 13, there you go, and ethnicity. So I like to remember this with the mnemonic CAGE. Can anyone tell me what creatinine is, what the relevance of it is, where in the body does it come from? Some of you who hit the gym might see it. Any takers? Muscles, yeah, fantastic. That's why the bodybuilders are having these creatinine supplements. But it's really, really relevant, on which I'll go into in my next slide. So if we look at this table of patient A and patient B, the electrolytes are the same, the urea is the same, the creatinine is different. Which one are you more worried about? B. Okay. I would agree, looking at just the table, but let's look at the patients now. Does that change your answers? Which ones are you more worried about? Are you worried about Doris, Lady A, or Brick, patient B? Okay, yep, Chris, you've changed the tune, and I would completely agree with you. And the reason why is because Brick here, our very well-built man, has a much larger proportion of his body is muscle. So he's naturally going to be producing more creatinine. So even though it's raised above the reference range, this might well be normal for him and his kidneys may be functioning absolutely fine. It's just that they're comparing it against an average man who isn't nearly as muscly as him. Whereas Doris, who's very wasted, as you can see, is going to have much less muscle. So even though her creatinine is only slightly above the reference range, if you compare it to her baseline, it's probably much, much higher than usual, which means that this is probably an underestimate of eGFR. So never just look at the eGFR, look at the eGFR and the patient to consider. Okay, that's the big take-home message from that. So yeah, you'd be worried about Doris, Lady A. Okay, so here's this general point is more from when do you order a U&E, or if you're on a ward round and the consultant says, why do we order a U&E? This is your reasons, okay? So largely, we said it talks about the kidney and it also measures these electrolyte levels. So it's useful when we're worried about kidney injuries or chronic kidney disease. Also, if someone's got slowly deteriorating function or any disease which affects the kidneys, can anyone name any conditions which might affect your kidneys in the long run? There's lots. Acidosis, alkalosis, yes, that often refers to sort of kidney. Yes, diabetes is a big one that I was looking for. SLE is a very good one for the people on Mod B. CMV, and knowing your research, yes, very well done, Zach. And yes, lupus, Nish's favourite topic. So any of those which could be damaging the kidney, if they come in, you might want to order a U&E to see how the kidney function is progressing. Importantly, we talked about how endocrine, there's lots of different systems. It often regulates your electrolytes as well. So endocrine emergencies and other conditions have very characteristic changes in sodium and potassium levels, which we'll touch on another day. but it's also useful for other patients. So anyone starting nephrotoxic drugs, so anyone who comes in with an infection and you think you might have to start antibiotics, it's really smart to get a UNE before you start them on, so you know what their baseline kidney function is. So if it is decreased in the future, you can see that it's actually the drugs that have done it. Similarly, any patient who comes in with a drug that's renally excreted, for the most part, many drugs are renally excreted. So you can take this one out of the bank if you're ever asked why we're doing a UNE. If a patient needs a scan with a contrast, those are just a few examples. A slightly more niche point is hyponatremia. UNEs are very good for detecting that. So here are some symptoms of hyponatremia, but these are only really symptoms that you get when it's sort of severe hyponatremia. And for the most part, up to 30% of hospitalized patients may have this hyponatremia when you have low sodium, but it might not manifest as this. It might not be so obvious. And studies have shown that actually patients who are older than 65 with this sort of minor hyponatremia are actually twice as likely to die during the hospital stay. So it's important that we're monitoring this and we correct it if we need to. But we talk more about correction of these electrolyte imbalances on another day, but just a useful point to touch on. Okay, moving on to the next one. LFTs. Can anyone tell me what an LFT stands for? Good, yeah. And can anyone tell me if I ordered an LFT, what sort of things might I get? What is it going to measure? Chuck a few out there. Good. AST, ALT, fantastic. Transaminases, good. Those are the transaminases are the AST, ALT. Any others? What do you have if you have jaundice? What thing is raised in your blood? Good, bilirubin. That's also measured. Okay, so these are just some of them. These are them, not even some of them. So if you order an LFT, this is what you get back. And so I've coloured ALT, AST in blue and ALP, GGT in yellow. And the reason I've done that to differentiate is because it helps us localise where their problem is. So these are really good markers if there's something going wrong with the liver, but it tells us more than that. It tells us where it's happening. So to simplify what the liver does, part of its function is to break down toxins, the actual liver itself, but it also converts hemoglobin, for example, from red blood cells into bilirubin, which it then secretes down the bile ducts, forms bile, and that's useful in our digestive system. So it does stuff, breaks down things, but it also releases bilirubin down these green bile ducts. So if ALT and AST are raised, the transaminases, that suggests a hepatitic picture. So specifically the hepatocytes or the liver cells, there's something wrong with them. Whereas if you have a raised ALP or GGT, that's suggesting more of an obstructive picture, suggesting that the pathology is actually, there's a blockage in the bile ducts. So it tells us a lot. Within these, it's useful to know which ones are specific. So there is of the blue ones, there is one that's more specific to the liver, and of the yellow ones, there's one that's more specific to this obstruction sort of thing. Can anyone tell me what those are? ALT, fantastic, Zach. Really, really good. Yeah, so ALT for hepatitic. I remember it for L for liver. So AST is also released from some cardiac myocytes and things like that. But L for liver, that's a specific one. What about for the yellows? Slightly harder, but please have a guess. It's 50-50 and no one's judging here. GGT, well done, Mox. Can you clarify your question, Zach? I'm not quite sure what you mean. But yes, GGT. So ALP is short for alkaline phosphatase, and if you can remember back to your second year MMB, that's related to osteocytes. So ALP you'll also see in bone conditions. So GGT is more specific. Good. Okay, so moving on. Bilirubin, like we talked about, is raised in jaundice. There are different types of jaundice. We will cover that in another day on gastro. But if you know for now, for all of your modules, if bilirubin is raised, it might suggest jaundice. And albumin is a more interesting one. had some teaching the other day. He said if both are raised rather than just ALP, I think it shows obstructive. Yeah, so basically, if ALP is raised, Zach, it could mean two things. It could either be this obstructive picture, but also because ALP is related to bone, it might suggest some problems with bone. So if you have raised ALP, it's really useful to have a GGT with it to know whether it's relating to the bone or whether it's relating to this obstructive picture here. Let me know if that didn't make sense. Okay, cool. So albumin is a protein that's produced by the liver. So in chronic liver disease, if it's not working very well, it's reduced. Okay, and this is a really, really important metric because it's actually testing how well the liver's functioning. The blue ones and the yellow ones are really good markers if there's something wrong acutely. So if there's inflammation or something like that, they're raised. But if it's chronic liver disease, when the liver's not functioning that well, they might not even be raised. So that's when we turn to our tests of synthetic function, of which albumin is one. The other ones are prothrombin time, or INR. I'll talk about how they're related in another later slide, and the platelet count. Okay, so if you know someone's got a chronic liver problem and you want to see how that's progressing, the synthetic tests, the ones in green, are way more useful. Okay, that's often a very, very common exam question as well, so hold on to that one. By the way, if you have any questions, whack your hand up so I know, and then I can slow down and be prepared for your question. Okay, coagulation screen. These are the things you get: prothrombin time, activated something, APTTT, fibrinogen, bleeding time. So it's worth noting that bleeding time isn't actually often done in clinical practice because it's a horrible test. You basically cut the finger and time how long it takes for their finger to stop bleeding. However, it's still often tested in exams. I don't know why, but we'll cover it for that reason. So everyone kind of hates coagulation, and it's very complicated, and some lectures can make it a lot more complicated than it needs to be. So I've tried to break down coagulation into two simple stages. Okay, so stage one, when you have that initial cut, you form this platelet plug. So platelets bind with von Willebrand factor, they attach to the site of injury, and they start to and they sort of coalesce, and that plug stops the initial bleeding. At the same time, but consider it as step two, you have this coagulation cascade where your coagulation factors in your blood get activated, they trigger this cascade, and it ends with the conversion of fibrinogen into fibrin, and the fibrin cross-links and forms our solid clot. Okay, so let's talk about how these relate to the coagulation tests. So like we said, this platelet plug formation is the thing that's stopping the initial bleeding. Okay, so the bleeding time is actually a reflection of this platelet plug formation. So if someone has a prolonged bleeding time, i.e. it's not working that well, it's increased, the things that can cause it is anything interfering with the formation of this platelet plug on this diagram. So if you've got low platelets in your blood, so that's called thrombocytopenia. If you have low von Willebrand's factor, and that's actually the most common cause because it's quite a common genetic disorder. Or if you have any drugs that are affecting the platelet function. So if a patient's on aspirin and clopidogrel, their bleeding time might be increased. Okay, moving on to number two. Think of the coagulation cascade, as I'm sure you know, in two separate pathways. You've got the intrinsic pathway in green and the extrinsic pathway in blue. Okay, so the intrinsic pathway is activated by something intrinsic within the blood vessels. It's the exposed collagen in the vessel wall. Whereas the extrinsic pathway is activated by this tissue factor, which comes outside the vessel walls, and that's why it's called extrinsic. It's very easy remembering the factors involved in the extrinsic pathway because there's only one. It's just 7. With the intrinsic pathway, there's that rule of letters. Okay, so I've tried to show it here. The last letter of the first factor is the first letter of the following factor. So 12 ends in E, E11, 11 ends in N, N9, and so on. Okay, they all coalesce on this final common pathway, which forms this fibrin. Okay, the other really useful mnemonic for you for coagulation is this. Okay, so it's my favorite. Asians play table tennis, and table tennis is indoors, so therefore APTT refers to the intrinsic pathway, whereas you play tennis, PT, outdoors, and therefore it's the extrinsic. Okay, so if prothrombin time is extended, that suggests it's the extrinsic pathway. That's suggesting there's something affecting factor 7. Okay, we won't go into specifics or things like warfarin or things like that. We'll save that for another heme day. Fibrinogen levels reflect the last step of the cascade. So if you've got low fibrinogen, even if your APTT and your PT are normal, you're not going to be able to form this fibrin clot. Okay, so that's a really important step, and we need to measure that to see whether we need to supplement fibrinogen if it's low in patients. So to recap on this coagulation screen, PT, you play tennis outdoors, so it's extrinsic. APTT, Asians play table tennis, but all you guys can too. You know, it's not just for Asians. Inside, so intrinsic pathway. Fibrinogen is just the last step of the clotting pathway, and the bleeding time is reflective of the platelet plug formation. So anything that interferes with that is what causes an increased bleeding time. Hopefully that's made it a bit simpler. If you have any questions, fire them away. One very quick slide on thyroid function tests. If you can remember back to your second year thyroid axis, if you understand this diagram, then you will understand everything related to hypothyroidism and hyper. So you've got TRH release, thyroid releasing hormone from the hypothalamus, which encourages your pituitary to release thyroid stimulating hormone. Thyroid stimulating hormone acts on your thyroid to make it produce T4 and T3, which are the actual active hormones which produce the effects of the thyroid axis. Importantly, T4 and T3 have this negative feedback loop, so they inhibit TSH and TRH, which means their levels are reduced, so you don't have overactivity. So the things that you get from a thyroid function test are TSH and your free T and T4. I would always recommend looking at TSH first. Okay, usually if you have raised TSH, because there's less it means there's less negative feedback from the T3 or T4, suggesting hypothyroidism. If you have low TSH, it's suggesting hyperthyroidism, because you've got lots and lots of T4 and T3 that's acting negatively and inhibiting and suppressing TSH. Looking at the T3 and T4 levels helps you confirm. I'd say look at TSH rather than the T3, T4, because sometimes if you're monitoring patients who are taking the T3 or T4, it's more useful to look at the TSH because T4, T3 are affected by the drugs that they take. But there is a very rare case where if you have an adenoma, so a tumor in your pituitary gland, which secretes TSH, that would give you raised TSH and then also raised T3, T4. But this is really, really, really rare. I think Pam Houston says she's only seen it once. In fact, if you see that T3, T4, and it's actually probably more likely to be an assay error. So you repeat the test. The other final point. Yes. The other point is if TSH is deranged but T3 or T4 is normal, it could be a subclinical case of hypo or hyperthyroidism. So it's really important to monitor these patients because they're more likely to develop clinical hypo or hyperthyroidism, but also they might already be exhibiting symptoms. So sometimes you do treat subclinical hypothyroidism, for example, if they have symptoms. Some other very specific tests, which will be useful for you guys to know on the wards. CRP, ESR, Issi already talked about those. They're both raised in inflammation and infection, but they're not very specific. CRP, which is an acute phase protein, is sort of closely follows the patient's clinical state a bit more. So if they get really unwell, it will go really high, and as they recover, it will slow down. Whereas ESR is better for monitoring chronic inflammation. So for all of you who are on Mod B, on Room, there is a very specific condition which gives you a raised ESR but a normal CRP. Can anyone name that? It's very specific, so don't worry if you don't know. But it's quite a common exam question as well, and it's pretty specific. Okay, I'll take it that you don't know. Don't worry. It's SLE, Anush's favourite disease. Sjogren's also does it. Very well done, Zach. So Sjogren's and SLE are the two rheumatological conditions which give you a raised ESR but normal CRP. Troponin, can anyone tell? Very well done. Good guess. Does anyone know what troponin is used for? Heart attacks, really good. So specifically, it's useful in acute coronary syndrome. So I did Mod A last, so I spent ages not knowing what ACS is, but it's like a catch-all term for people who come in with STEMIs, so MIs, whether it's ST elevation or non-ST elevation, but also unstable angina. So that should read normal and unstable angina. Sorry. So troponin is raised in a myocardial infarction, but normal in an unstable angina, and angina for that matter. D-dimer. Can anyone tell me what D-dimer is? When we use it? Coagulation problems, really good, because D-dimer is released from the breakdown of clots. More specifically, it's a very useful marker for PEs and DVTs, because if you think about it, a pulmonary embolus is just a clot that forms in your blood vessel. So, as I said, it's a product from the breakdown of this clot. So it's raised in PE and DVT, but like you said, in coagulation problems, there's lots of things that can cause it to be raised: infection, malignancy, pregnancy. So it's not a very specific marker. If you've seen a raised D-dimer, it doesn't mean we should panic and think PE, but it's a clue. And more likely, if it's normal, then you can quite confidently rule out something like PE. Okay. And group and save. Can anyone tell me what group and save is? For transfusion, fantastic, Misako. Okay, so matching blood group. Well done, pair of you. So it identifies the blood group of a patient. Okay, so one thing that I really struggled with, because doctors kept on saying different things, is what is the difference between a group and save and a cross match? Okay, so if you ask any anaesthetist, they will say that a cross match is when you just supply the patient's blood. So group and save is identifying the blood group, cross match is providing the blood. If you ask a hematologist or a lab scientist, they say cross-matching is an actual specific test where you get the blood bag you're about to give to a patient and then test it with the patient's plasma to see it's compatible before providing it. Just wanted to mention that there in case you see lots of different definitions and get confused. But largely they apply to the same thing. You have the blood bag which you're about to give to a patient. Okay. So I wanted to finish. Oh, before I wanted to finish, we've got the order draw. So now that you're all apprentices, they might get you to take blood, in which case it's really useful to know what order to take the tubes in. There's lots of different colours here. So there's a mnemonic, but I think largely you'll be taking 3 different colours. It'll be a light blue, it'll be a gold, and it'll be a lavender. Always remember the most important thing, to take lavender last. And that's because the lavender tube contains a very specific reagent called EDTA, which sort of lyses your red blood cells, I think. And if you do that first, it contaminates the rest of your blood samples, and that can give you false results. So if you do the lavender before the gold, your patient might come out as having really high potassium levels, and people might get really panicked, but it's actually just because you took it in the wrong order. So this is really important. Let's put this into practice though. So I've got case studies, very short case studies for each of the modules, just to show that it's really useful for all of you to know it. Okay, so we'll start with Mod A. We've got Mr. Mike Oplasma, a 56-year-old Irish man who's brought in by ambulance after 5 days of shortness of breath and coughing up green sputum. These are his obs. This is his chest X-ray. It's a pretty clear-cut picture. But I want you guys to tell me, what blood tests would you order and why? Yes, bonus points if you get the terrible puns. They're excellent puns, Anush. I spent all night thinking about them. So you don't need to give me a full list, just give me one that you would do. This is abuse, Anush. Full blood count, fantastic, Zach. Any idea why you'd order a full blood count? See the white blood count. Excellent. Yeah, it might be raised in infection. Fantastic. Any other offers? What else would you do? Would you just do the full blood count, or was there any other blood tests? Please, guys, just like go for it. Chances are I've listed it. Troponin and CRP. Okay. You might be worried about CRPs definitely, because it might be raised in infection. Troponin is also a good shout, maybe, because if he's complaining of chest pain, you might want to rule out something like a heart attack. Any other guesses? Screening for virus? Yeah, especially in COVID times, absolutely. Exactly, yes. I will just put the rest. Okay, so full blood count, just like you said, Zach, to look for raised white blood count. U's and E's are incredibly important here. Okay, there's two reasons. It's first to check how their kidney's working before you dose the patient up on antibiotics, but also, this is a pneumonia, by the way. The thing that will get drilled to you in your teaching and also in exams is this Curb 65 score. So it's used to decide the prognosis and therefore how strongly you should treat pneumonias. And one of the things in Curb 65 is the U for urea. Okay, so you'll often see an SBA that's like, what is the most important blood test for the prognosis of this patient? And it's actually, thank you, Mox, well done, good stuff. It's actually the U's and E's because it gives you the prognostic value with the Curb 65 score. So that's another exam tidbit to store away. CRP, ESR, like you said, Nicole, raised an infection. And I would also say do a blood culture. Okay, so the general rule by thumb in the hospital is if they have a temperature, basically, if they're feverish, do a blood culture. Another thing, practically, if you're ever asked to do a blood culture, you take two bottles, an aerobic and an anaerobic bottle. Which do you take first? 50-50. Anaerobic. It's unfortunately okay. I might be wrong now. I'm worried. I would say it's the aerobic first because when you do venipuncture, there might be the tiniest bit of air in your butterfly. So you want that to go into the aerobic bottle, and then when you're swapping bottles for the anaerobic bottle, then you know it's just going to be blood that goes in and no air or oxygen. So aerobic first, anaerobic second. Okay, onto the mod B's. We've got Henrietta Issi, known as Hen to her mates, is a 68-year-old woman who's brought in by ambulance after vomiting a large amount of blood. She was found in her home next to many, many empty whiskey bottles. What blood tests would you... Oh, these are her OBS. What blood tests would you order and why? LFTs, really, really good, because you're thinking maybe there's a liver problem here. Good. Full blood count, why are you thinking that, Nicole? Yes, LFTs, all of you who've gone for that, fantastic. Well done for recognising that. Why would we do a full blood count? Anemic, very, very good. Yeah, if she's vomiting loads of blood, she might have low HB, and we'd use that to decide whether we need to give her a blood transfusion or not. Thinking about blood transfusions, what else might be really useful in this patient? Yeah, group and save. Well done, Somar. Fantastic. Okay. So yes, I've pretty much done the same things. Full blood count to monitor HB levels, but also the platelets. You know, if you're thinking about synthetic function of the liver. LFTs also to assess liver function. U's and E's. This is a very specific piece of knowledge, so don't worry if you didn't know this. In an upper GI bleed, you often see a raised urea, but normal creatinine, and that's because your body's digesting the protein in your blood, so that gives you a raised urea. But also, if she's vomiting loads of blood, she might be dehydrated, so that might lead to an AKI. So worth doing a U and E there. Coagulation screen, especially if she's an alcoholic. Yeah, well done, Mox. You're getting them all. Fantastic. Coagulation screen, especially if she's an alcoholic, she might not have a very good liver function to produce coagulating factors. So if that's complicating her upper GI bleed, then it's worth knowing. And then group and save and cross match, like you said, Somar, well done. On to our last case, powering on through. We've got Diana Ria, a 28-year-old woman who presented to A&E after a recent trip to Argentina. She's been vomiting and suffering from diarrhea for the past 5 days. There are OBS. What blood tests would you order and why? Get used to asking yourself why, because it's really, really important to know what you're looking for when you're ordering a blood test. Otherwise, it's just a waste of money. Good. Use and E's, check electrolytes. Fantastic. Well done, Nicole. Anyone else? Blood cultures to check for infections. Really good. Raised temperature. Very good. Full blood count. Okay. Blood culture. Well done, Mox. Yep. Why are we getting a full blood count in this lady? Check iron. Yeah. Good. Yeah. Also, maybe to check for infection. So, recent. You'll notice if ever there's a stem of someone coming back from a country, it's often infectious diseases related. So maybe, especially if she's got a raised temperature, she might have raised white blood cells as well. So yes, full blood count to look for white blood cells, but check iron, why not? Always the full blood count, as Izzy says, and I probably would say she's absolutely right. Yes, like Anush says, you're giving really, really good justifications. You're showing excellent knowledge, so well done, all of you. Your UNE can also show for dehydration if she's been, letting a lot of fluid out from her bowels. But also, if you're going to give her antibiotics, it's good to see the baseline kidney function. CRP, ESR is another one that we didn't mention. Raised in infection. Blood cultures because of the raised temperatures. In this case, because it's sort of a gastrointestinal infection that you're worried about, a stool MCNS is useful. So MCNS stands for microscopy and microscopy cultures and sensitivity. So and then this is a bit of a rogue one, very, very niche. But hepatitis A presents with this kind of diarrhea, vomiting kind of pattern, and it's more prevalent in South America. So well done if you were thinking that, but really, really don't worry if you weren't. You've got the really important core ones. So fantastic, all of you. I hope you feel a bit more happier with the general bloods. Just to cap off the session, we've got this feedback form. If you want to use your iPads to scan the barcode, or Anush has posted the link, we'd really, really appreciate your feedback because, like we said, this is the first kind of time we're teaching online. We want to know what works for you, what doesn't work. We're using your feedback already to change what we're doing in teaching. So I know one of you asked for Menti, so I tried to use that in the beginning. One of you asked to talk more about general on-the-ward tips, so I'm really happy to stay right now and talk with you guys if you have any questions about how to make the most out of being in clinics, things like that. So yeah, we are changing. This isn't just for us to have a tick in the box feedback. It's really for us to make these sessions better for you. So in hepatitis A, if it's a sort of florid infection, you might get raised transaminases. So we talked about the hepatitic picture. The blue ones, AST, ALT, might be raised. Very good question.
One other thing just worth saying. When you're in a hospital, they like to order way more blood tests than you will think are appropriate because ultimately there is a sense of liability in case they miss something. It's called defensive medicine, but it is quite common where they check completely random things just in case they don't miss something.
Yep, I'm very happy to recap albumin. So let's go to the LFTs page. Okay, so we talked about this hepatitic obstructive picture. So these transaminases, the ALT, AST, and the ALP and GGT, they're not actually part of what the liver isn't working as its main function to produce these. They're just really useful markers. So in the case where there's inflammation in hepatocytes, because they rupture and die, they release ALT and AST. So that's raised. But just because they're raised, it doesn't mean, just because, if the liver's not working, say because lots of liver cells have already died, there's probably not going to be that much ALT, AST. So whilst these markers are really good in the acute, if something's damaged the liver very recently and you've seen these things raised, they don't actually tell you in the long term, say in an alcoholic, over 20 years, how the liver's functioning. So what we use instead is these tests of synthetic function. And you measure these three things. You measure albumin, you measure this prothrombin time, and the platelet count. Okay, because they are what the liver actually does. The liver produces albumin. The liver produces coagulation factors, which affects the prothrombin time. The liver produces a hormone which affects the platelet count. Okay, so if these are low or sort of disturbed, it means that the liver's not working. So whilst the other ones are useful for sort of being a marker if something's gone wrong in the acute, in the chronic, when you're monitoring someone in the long term, these tests of synthetic function are really what the hepatologists are looking at. Yes. So yes, Omar, these are all measured from the blood. So when you order an NFT, you just click it on the ordering menu, but it's measuring these specific things. Okay. Any other questions about anything that we've covered, or things about clinics? How have you guys found it? It's your first week, right? Have you felt involved? Have you felt part of the team? Have you felt like you've kind of gone to a ward and you're like, oh, what do I do? Where do I go? because that was basically me for the first 3 months, so don't worry. How do you get someone to sign you off on a CBD or a mini kex? Okay, really, really good question. I'm glad you like wards, Nicole. Me too. So basically, a CBD is a case-based discussion. So if you speak to a doctor about a patient, if you present them, whereas a mini kex is them observing you doing a clinical examination. So most of the time, the harder ones to get are mini kexes because you actually need to have the doctor there and present to see you do the exam. With a CBD, you can go off, speak to a patient, take a history in your own time, do an examination in your own time, and then if you find a doctor and just go, do you have a spare 5 minutes for me to present this patient to you? They'll often say yes because they know the drill. They know they've had to do it before as well. A mini kex, you'd have to say, can you observe me doing this Abdo exam? Well, the way you actually do it is you use the NHSE Portfolios website. There's a tab called tickets or ticket requests. If you go on that and then press create ticket request, you just plug in the doctor's email. So find a friendly junior doctor or a consultant for that matter. Say, would you be able to sign me off on this SLE? Take their email down. And then also as a quick tip, when you're asking for an SLE, ask if they want feedback on their teaching for you, because A, it'll make them love you, and B, it'll probably make them more likely to actually complete your tickets, right? The best way to a doctor's heart is feedback forms, so always offer that. When you're actually...
Oh, sorry. Just to add on to that, send it like on the day or the day after, because the JIT, they just forget and it gets stuck in their, like, they get like 70 emails a day. So often, like, we notice that if you sent it like a week after, they'll have probably sadly forgotten having done it and they probably won't do it. So just get it off the bat and write in the comments like something for them to remember you is what I would do.
The other thing is, sorry, go ahead, Anish.
Put your photo on ePortfolio because visual memory is better than whatever else. They'll recognize your face, hopefully.
The only other thing to make sure that the doctors actually complete your tickets is make it as easy as possible for them with a mask on. You've got very recognizable eyes. I'm sure that works. So make it as easy as possible for them to complete the ticket. So often in my sort of comment section, I'm going, dear Dr. This, thank you for seeing me today. When we did this in person, you told me that I did well in this. You told me I should improve this. And then all they need to do is copy and paste exactly what you said into their own columns. So it takes less than a minute for them to complete. But I found that if you just left it empty, they're less likely to complete it.
Yeah, that's something I used to do as well.
In a mini kex, you do the full comprehensive exam. I've seen some doctors in clinics do only certain parts of the exam. So it depends on the consultant. Stratton, who you might well know at the Royal Free, gave me a mini kex for just putting my stethoscope on someone's chest for like 2 seconds. It depends on what the consultant says, but most of the time you don't really do a full comprehensive exam on the ward round, for example. So I'm sure they'd sign you off on that bit. I mean, if you don't ask, you don't get. So don't feel like cheeky by just being like, oh, could you sign off as an SLE for me for that?
I think also you need to kind of play it as it goes, because obviously if it's a busy clinic, you probably won't be able to do a comprehensive exam and practice all of your communication abilities. But if you are in a specific bedside teaching session, I don't know if those still happen, but if they do happen, then you can definitely do a complete examination. Rheumatology is technically every single ortho exam, but the really important thing to know before you start rheumatology is go over the hand exam. It's like the bread and butter examination.
So yeah, the hand exam is great because it's really easily tested in OSCEs, because all you need, because a lot of hand signs are very stable. So you're not getting in very sick patients to do that, but also it's quite easy and it can be done in 5 minutes. So
we'll talk a little. I think Izzy's going to talk a little about hand signs next week, because the hands are pretty much like
the hands are the window to the soul, guys.
Yeah, you can get. I'll tell you a quick story about my year 4 OSCE. I saw something on the hands and got the diagnosis within the first 20 seconds of an OSCE station. So like honestly, like hands are so important in terms of examination.
I mean, just so much of room is just on that initial inspection. Like the minute that they walk in the room, their hands, their face. We'll do some like next week. It'll be good.
Yeah, next week we're going to focus on how you can just figure out what's wrong with someone just by looking at them. It'll be fun.
Any other questions about sort of clinics life, resources, things like that? I'm happy to talk about that. And also, yeah, feel free to go and enjoy your Friday evening. Thanks for joining us.
We will
Friday is
avoid
not
Fridays henceforth. This was just a one-off because of
and
yesterday.
congratulations for graduating as well.
Yeah.
Yeah, congrats, guys. Halfway.
Pleasure, Chris.